All right, we'll get started. So how's everybody doing? Last week in your minor tracks, working towards that 45 reps, remember, we're shooting for this semester. So hopefully by the end of these 4 weeks, you're around 20, 25 for this semester. If you're way ahead of that, even better. I've been to pretty much every site, so I'm kind of seeing everybody's on track. And if you're not, you kind of have a game plan. So any questions about the reps? Anybody having any issues still kind of getting those reps? You can either, discuss it now, or if you want to come meet me later on, that's fine. But I generally have an idea of where everybody is, and I'm pretty comfortable with your progress. Today we're going to be talking about flow phenomena, mainly really talking about blood flow, but where else do you get flow when we're talking about MRI? CSF, yeah. So the two main fluids we're going to be talking about today are blood and CSF. I'm going to just display it like this because the Ink2Go doesn't really capture it when you actually put it in the full screen mode. So I don't want it to kick it out and not record. So that's why I do it this way. All right, so here are our objectives. We're going to be exploring artifacts produced by those flowing nuclei, which move during our image acquisition. So we have stationary nuclei, so like your muscles, your tendons, your bones, all those things would be considered stationary. And then CSF and blood is going to be flowing and moving across those gradients as we're scanning. So we'll talk about how the phase is going to be changing with those nuclei compared to our stationary nuclei. And then that creates a different contrast compared to our stationary nuclei. So in most MRA, or MR angiography, we are trying to null or basically darken the stationary tissues so that our flowing nuclei is fresh and appears bright on our image. Then we're going to be talking about primarily nuclei from blood and CSF, and then we're going to talk about the causes of those mismapping of signals that results in artifacts, and that artifact is called phase ghosting. So if you've seen those artifacts, like if you've seen like an aorta on an abdomen scan that actually traverses your scan, creates this little phase ghosting artifact, that's what we're going to be talking about today, and how to maybe possibly eliminate that altogether and increase the signal within that aorta better. So these are the three main things we're going to be talking about today: flow mechanics, flow phenomena, and then the flow artifacts in their compensation. So this is an image of what area of the body you think? Kidneys, abdominal aorta. Yep. So you can see here, you got your, what is this right here? As it leaves the heart? Your arch. And then it goes down into the what? Descending aorta, and then your abdominal aorta. And then branches off into your renal arteries there. And then it breaks off into what? Iliac arteries. Good. All right, there are 4 classifications of flow. So first is our laminar flow, which is also sometimes called parabolic flow. You have your spiral flow, which also can be referred to as helical flow. Number 3 would be vortex, and 4 is turbulence. So you can see here a little bit of how they draw these flow mechanics within the vessel here. But we'll go over each one of these. Laminar or parabolic flow. This is where you have different but consistent velocities across the vessel. So you can see here, we're all having a constant velocity, but closer to the vessel wall, we get a little bit of friction, increased resistance, so our velocity actually decreases. It slows down closer to the vessel wall, but it's still constant. So think of water through a pipe. have more friction closer to the piped wall. So the flow at the center of the lumen is going to be faster than near the vessel wall. So sometimes this creates two different problems. It causes what we call intravoxel dephasing, because some nuclei are flowing faster than the nuclei closer to the vessel wall. Anytime you have two different phase, meaning at different times with your clock, so imagine the nuclei that are right in the middle are flowing faster, so they're actually going to be moving along those gradients quicker, so they're going to dephase a lot faster compared to the ones that are moving closer to the wall. And anytime you have a voxel with a bunch of spins, nuclei that have different phase positions, you're going to get an overall decrease in signal. So one problem that's caused by this parabolic flow is what we call intravoxel dephasing. And I put some of these things in the notes. So if you guys are watching these PowerPoints and listening to them, always refer to the notes too, because I always put a lot of good stuff in the notes too. The other problem is with that slow flow near the vessel wall, if you have slower flow, it might actually receive more RF pulses. Just because that blood flow is going a lot slower, you're going to get more RF pulses, and more RF pulses equal saturation. And remember, partial saturation and full saturation, both of those equate to less signal. So what happens is we have less signal near the vessel wall, so it actually makes it appear like the vessel's a lot narrower than it actually is. So the radiologist might think it's stenosis, but it's really just how the MRA is projecting that vessel. It's got faster blood flow in the center, and then near the vessel wall, you're receiving more RF pulses. It saturates those flowing nuclei, so it makes it appear like the vessel's a lot smaller than it actually is, small in diameter. Next is our spiral, our helical flow. This is velocities coil around each other in a corkscrew fashion. And these are typically seen in large vessels like the thoracic aorta. So just think larger vessels with this spiral flow. And the thoracic aorta, think of it, it's coming off that aortic arch, so that arch probably starts to cause the blood flow to spiral around the vessel. Next is our vortex flow. Initially you have laminar flow. So you can see here it's that parabolic flow, constant velocity. Then you approach a stenosis, and a stenosis just means the narrowing of the artery of the vessel. Could be plaque, arteriosclerosis that's causing that narrowing. Then you get what we call a increase in velocity through that stenosis. So it's going to speed up, because just like if you start to kink, have you ever washed your car and you don't have a proper spray, at the end of your hose? You actually sometimes just put your thumb there, right? And it reaches a lot further than if you just didn't have any pressure on that at all. So you're going to get an increase in velocity through that stenosis, and then once you pass that stenosis, you get that vortex flow. It spirals into a vortex, or swirling, often countercurrent eddies seen at bifurcations and after stenosis. So this can happen as stenosis, or near bifurcation where the arteries split, or if you have what we call an aneurysm, outpouching of the vessel, you get that vortex blood flow. And then finally we have our turbulent flow. This is where we have different velocities that fluctuate randomly. So nothing consistent. The velocity differences change along the vessel, changes erratically. So why is this important? Oh wait, last one, sorry here. So the last one is actually no flow, or stagnant flow. This is where you have, say, a pooling of blood. It could be caused by a dissected aneurysm. And here you can actually see that dissection within that thoracic aorta at the top of that aortic arch. You see that? So blood actually just pools there, and it's stagnant, meaning it's not moving. And then so the blood acts like stationary tissue. So if it is a T2 weighted blood that's been pooled, what's it going to look like? T2 weighted. Blood that is just sitting there, not moving. Dark. It's going to be bright, just like CSF, or, well, I mean CSF as in like the brain, like the ventricles, and around the spinal cord, and also like urine in the bladder. It's going to be fluid that's just sitting there, so it's going to be bright on our T2 weighted images. So this is our T2 weighted image here that's fat setted, and you can actually see flowing blood, but then you have blood that is pooled due to the dissection. Okay? So we have alternate terms to describe these different types of flow. So laminar or parabolic flow is often called first order motion because it's at a constant velocity. Our vortex blood flow is second order motion because remember it speeds up through that stenosis, it accelerates through that stenosis, and then it wraps around once it's gone through that stenosis in a vortex fashion. And then third order, it's often referred to as jerk motion, and that's due to that turbulence. It's inconsistent. We can't compensate for it. So in MRI, this is always a registry question, we can only compensate for first order constant velocity laminar blood flow. And it's usually when our slices are perpendicular to that vessel also. So we can only compensate, or we can only image blood flow and have it appear bright when it's at a constant velocity. And usually we have to be perpendicular with our slice orientation to that vessel. Unless it's a 3D sequence where we get a slab of information, and we usually use that for like our time of flight brain, where we can actually watch and look at those vessels moving in all directions. So we know our circle of Willis kind of moves in all directions. So we usually get what we call a 3D acquisition of those smaller vessels of the circle of Willis, and we're able to see those as bright compared to 2D slices that are going to be perpendicular. All right, so our next bullet is going to be talking about flow phenomena. Flow phenomena are what cause those artifacts. And there are three types: time of flight, entry slice phenomena, and intravoxel dephasing. This image over here on the right is what we call our time of flight source image, and we capture a lot of those images from basically the foramen magnum up to the corpus callosum. Has anybody done an MRA brain yet? You just basically put that box in that area, corpus callosum down to the foramen magnum, because that's where the circle of Willis is. And where do we put our saturation band?
It's not above his ear.
Above. Everybody's doing this. Above, because we're trying to saturate what vessel? Venous blood flow. Good. Because it's an MRA, not an MRV. We want to saturate our venous blood flow. So we put that sat band above. And this is what we call it MRA source image. And then basically you get all those slices. It's a 3D acquisition, really thin slices. And then it collapses down into one image. And that's what makes that really pretty axial view of our circle of Willis. So this is a source image. It collapses down into our collapsed image. And usually we reformat our collapsed image. And what do we do there?
Start cutting.
Start cutting. So when we go to our post-processing, do we select MPR or do we select MIP?
MIP.
MIP. And we usually MIP our circle of Willis anterior and posterior, and we spin it and tumble it, do both of those, and send that on to our radiologist also. And then this is kind of what it looks like, right? This is our time of flight after we've nipped the stationary tissue. This is both the anterior and posterior circumvallus. Is this a coronal sagittal or axial view of the circumvallus? So what? Not axillary.
Axial?
Huh?
Axial?
Axial, not axial.
It's corona.
It's coronal. Coronal. So if you guys go to your MRAmaster.com, great website for anatomy. You guys probably use this in cross-sectional. Here is your axial, anterior, posterior. Here's your coronal, and here's your sagittal. So this is a good way to know the anatomy that you need to not cut out with your mipping. So you usually just separate the two. A lot of people usually start on the axial, and they separate by cutting these communicating arteries here, right in the middle. And then once you separate it, then you can cut them in the other planes. And you know, you can manipulate it with the mipping to get really cut out all that stationary tissue. But that's our time of flight. All right. So when we talk about time of flight, we usually want to refer to both spin echo and gradient echo. So that's why the degree of time of flight effect present in the image is pulse sequence dependent. So for us to get a useful echo or signal from that tissue, the nuclei must be excited, our excitation pulse, and rephased. And in spin echo, we use what do we use to rephase? To bump that signal back up. 180 degree refocusing pulse. Good. But what do we use in gradient echo? We just tested on this. We use gradients. Yeah. And they could be on the slice select, they could be phase, or they could be frequency encoding gradients to bump that signal back. Which one does it more efficiently? Which one bumps that signal up higher? Remember T2 versus T2 star. Which one just generally has better signal? Spin echo or gradient echo?
Great.
Spin echo. So spin echo does a better job at rephasing because of that 180 refocusing pulse. So our stationary tissues, because they're not moving in that slice, are going to usually receive both. They'll get the excitation, and then they'll get that 180 degree refocusing pulse, or the gradients will refocus. As opposed to flowing blood. This flowing blood might be in the slice when it is excited, but then it leaves the slice before it actually gets the chance to be rephased. So that signal drops very fast, and then you actually have no signal by the time you sample it with our frequency encoding gradient. So that's why time of flight effects are pulse sequence dependent. So here's just a little drawing that kind of shows that. So we have flowing blood coming into the slice. It received a 90 degree excitation pulse, but then it has exited the slice before it receives 180. That creates a signal void within that vessel. Okay? Signal void. So a lot of time radiologists have to clarify that, with other MDs, what an actual signal void means. The signal void might be created by our scanner, not by pathology within the patient. Sometimes they're thinking, oh my God, there's no blood flow within that vessel, something's wrong with the patient. No, it's really just the MR pulse sequence that we use caused that vessel to look dark. So anytime you usually see a vessel that is dark on MRI, usually it's just denoted as signal void within the dictation, okay? All right, so let's talk about spin echo first. So remember, in spin echo, here's our pulse sequence diagram down here. We start with a 90-degree excitation pulse. Our slice select gradients turn on anytime we have an RF pulse. Then we select our frequency encoding gradient. We can either go steep or narrow, depending on which area of K-space we want to fill first. And then we usually sample our signal with our frequency encoding gradient, which is also called what? Readout gradient. All right, starting to come together. So see how this 180-degree refocusing pulse is also slice selective, meaning those flowing nuclei have to be within that slice to get rephased appropriately. So in spin echo, every slice therefore excited and rephased. So stationary nuclei within that slice will receive both. That stationary tissue is not moving. So it's going to receive both. However, flowing nuclei, and remember it has to be perpendicular to that slice. So if you have your aorta, you want an axial slice. Your abdominal aorta is going, superior to inferior. You want an axial slice. Okay? Carotids, you want an axial slice because they're going up in the neck. So flowing nuclei, which is perpendicular, may receive the excitation pulse, but then it might exit before it's being rephased. So it might receive that excitation pulse. So this little description right here is associated with this second drawing right here. So it gets the initial excitation pulse by that 90-degree RF. Here's our slice thickness. The slice thickness could be 3 millimeters, 5 millimeters. It all depends on what area of the body you're scanning. But then that flowing nuclei has already left the slice and gone into maybe the next slice before it's received that 180-degree refocusing pulse. So then you get no rephasing equals no signal. If it receives both, so if it's, say it's really slow moving blood, like venous blood flow, so in this case, it received the excitation pulse, but it was so slow it didn't leave the slice before it received the refocusing pulse, so it actually creates signal. And then the third scenario would be that flowing nuclei actually was here before the excitation pulse even happened within the slice, so it hadn't even entered the slice, but then it got a 180-degree refocusing pulse, meaning it basically started from the top and went completely full saturation, so we get no signal again from this scenario. So if I draw 3 boxes, so this is our vessel. This is our voxel around that vessel. So in this scenario, we get signal. So what's this vessel going to look like? Bright or dark?
Right.
Bright. And then here, no signal, so it's going to be dark. And then the third scenario is going to be dark again. So is the radiologist going to say in these two situations, no flow or signal void? Signal void. Because that's just the system causing it to look dark. It's not necessarily the patient. They have ways to rule out if it isn't actually like an occlusion, and that could be, causing what we call like an infarct or a stroke. So they have ways to really determine if there actually is no blood flow. For right now, we're really just talking about what the MR system does in terms of angiography. So our time of flight effect depends on three things. How fast that blood is moving, our TE, which is what? Echo time. Remember, it's always reversed, echo time. And our slice thickness, how thick that slice is. 3 millimeters versus 5 millimeters versus maybe less than 1 millimeter. And it's really important when we talk about TE to remember our tau. What was tau? Does anybody remember?
Half TE.
Half, it was half TE, but what is half a TE? From when to when in spin echo? When is a half a TE? You have two of them, and they should be equivalent.
Isn't it from the peak of the first excitation pulse, like halfway to the other one?
Good, good. So let's go back to that spin echo diagram.
I can draw it.
So right here. So here we got our spin echo diagram. So from they don't draw it in true representation here. But let's just draw a line. So our first tau is from 90 to 180. So this is 1/2 TE, which equals tau. And then this should be equivalent from 180 to peak echo. This should actually be the same length because they're the same amount of time, but they just don't draw it in true representation. But then our other half of tau is from 180 to peak echo. So this is once again 1/2 TE this tau. All right? So remember, I said if you don't receive that refocusing pulse, you're not going to get signal from that flowing nuclei within that slice. So you can see here how as we increase our TE, we also increase that first tau from the time of excitation pulse to that 180. So that first one, first parameter that affects our time of flight effect is high velocity signal loss. So if we increase our flow velocity, so are we thinking arteries or veins here? We're thinking arteries. So put off the side here, thinking arteries. We're going to increase our time of flight effect, meaning we're going to lose signal. So time of flight effect is sometimes associated with, it's also called this high velocity signal loss. So if we're increasing our time of flight effect, we're losing signal within that vessel. So fewer nuclei are present in the slice to receive both excitation and rephasing because it's so fast. This decreases signal in that area. Signal is lost. Thus high velocity signal loss or high velocity signal void. Once again, it's a signal void. So here are your expected velocities for different vessels within your body. So you can see here we have velocity in centimeters per second. You can see here how our thoracic aorta is the fastest. Second fastest is your abdominal aorta. Then you got your femoral artery. And then you have various things over here. Subclavian, carotid arteries. So you guys have seen that. Like, you've seen how quickly it happens, right? Especially when you're doing those MRA of the neck. It's like, you gotta be ready. You inject that contrast or you deploy your power injector. How long does it usually take from when you hit that button to when it's starting to go up your carotid arteries? How long? Yes, huh?
Seconds?
Yeah, like
10 to 12 seconds. I mean, it's quick. Depending on where you started your IV too. Like if it's in the hand, it might take a little bit longer compared to your antecubital. So always be ready. If you've hit the power injector and it's already like 30 seconds of the pass and you haven't hit that to start recording, you usually probably missed it. And you're going to get that basically that venous superimposition. So you're going to get the venous blood flow superimposing over your arterial blood flow. So you better be really good at cutting out those carotid arteries to remove that venous blood flow. So if we talk about slower velocities of blood, like our venous blood flow, this is going to decrease our time of flight effects. So we're going to have high signal. High SNR in vessel. So more nuclei are going to be excited and rephased, so they'll receive both RF pulses. So signal is going to be higher. And we'll get what we call flow-related enhancement. Flow-related enhancement. Echo time, our second parameter that affects time of flight. So the longer our TE is, so the time from, remember TE is from your excitation pulse to our peak signal, that's TE. So our TE is from excitation pulse to peak signal. So then we'll have more time between the application of our excitation pulse and our rephasing, our tau, our first tau. So as we increase our TE, you can see how that will start to stretch out the time between 90 and 180. You guys see that? So our 90 and 180 pulses are going to be further apart, have more time, more milliseconds between those two. So more nuclei will receive only that excitation pulse. This creates a signal void. And then finally, our third parameter that affects time of flight is our slice thickness. If we increase the slice thickness, we're going to decrease our time of flight effects. So what does that mean? Does that increase signal or decrease signal?
increase.
Good. This will increase SNR. So it takes longer for those spins, no matter what their velocity is, to travel through a thicker slice. So a 5 millimeter versus a 3 millimeter, thicker slice. So more nuclei have a better chance of receiving both the 90 and the 180. So in this diagram, if this is, say, 3 millimeter slice thickness, I would just increase my slice thickness to look something more like this. And now we've received the 90 and the 180. So now it's been excited and rephased, and that will create signal. So our first yellow box here would be, say, 3 millimeters, and then our red slice is going to be 5 millimeters. So better chance of catching that flowing nuclei. All right, so remember I said time of flight effects is dependent on what? Those three things, but mainly what? Our pulse sequence. We've been talking about basically spin echo this entire time, where you get the 90 and 180. But now we're going to talk about gradient echo, which you guys have covered last unit. Remember gradient echoes, we don't really have a 90-degree flip angle. We have what, less than or greater than 90? Less, a variable alpha flip angle. And then we don't have the 180 refocusing. We use gradients to refocus. So it's not as efficient at refocusing. So it's T2 star weighting, typically. And it doesn't correct for three things. Melody, I know you got those memorized. What are those three things?
The aim homogeneity, the stability, artifact, and
One more. Chemical shift. Chemical shift, yeah. So remember, the gradients do not correct for those three things. So that's why usually you don't want to scan a patient that has a knee replacement that has metal in it, because it's going to create a larger metal artifact with a gradient echo versus a spin echo. So typically with metal artifacts, you want to use a stir, because you use a 180 inversion pulse, and then a 90, and then another 180 refocusing pulse. So a stir sequence is perfect for a metal artifact. All right, so here, excitation pulse is the only thing that's slice selective. So we're just exciting that one slice on the initial excitation pulse, but then look, that slice gradient is not being turned on later on. When we use our gradients to rephase our spins, as you can see here with our frequency encoding gradient, where we dephase and then rephase, these happen across the entire volume of the scanner. So even if that blood flowing nuclei is in our foot, we excite it there with a slice select gradient, and then it's moved all the way up to your heart. It's gone all the way back to your heart. You can still rephase it because you have gradients along the entire length of the bore of the magnet. So flowing nucleus receives an excitation pulse and is rephased regardless of its slice position and produces signal. So it will create a flow-related enhancement. So anything that receives an excitation pulse will be rephased. So that's why typically gradient echo pulse sequences are also sometimes referred to as flow-sensitive sequences. Flow-sensitive sequences. It does another great thing because remember we use a very small flip angle because that's to compensate for our really short TRs, right? Gradient echoes are really fast, right? Compared to our spin echoes. We're usually doing these during breath holds, things like that. So our TRs are really short, so then our flip angles are not 90 anymore to reduce saturation. But we don't really care about the stationary tissue when we're doing MRA. So we want those stationary tissues to receive as many RF pulses as possible so that the stationary tissues start to get more and more saturated. So the saturated tissues, which is stationary, will have dark signal compared to our flowing nuclei, which is, it comes in fresh. It hasn't received any RF pulses once it gets into that slice, and it will appear bright on our image compared to our stationary tissues that have been repeatedly beaten down. They call it beaten down by our RF pulses. So flowing nuclei will be fresh, stationary tissue will be beaten down. So let's put that on here. Stationary tissue beaten down by repeated RF pulses. This equates to saturation, and this gives our just basically zero signal. I'll just put a 0, so I'm running out of space. Compared to flowing nuclei, which will be fresh, because comes into slice without RF pulses knocking down vectors. So remember, we're talking about our net magnetic vector being knocked down into full saturation. So that fresh flowing blood that comes into the slice has not seen all those RF pulses, so that's going to appear bright in your image. Initially, until it starts to go deeper and deeper into the stack, and then it receives more and more RF pulses.
What does that say, fresh?
Fresh because comes in, or you could say fresh because flowing nuclei comes into the slice without receiving any RF pulses that knock those vectors down. So, quick recap of time of flight. So, high velocity signal void increases when you have, so no signal for this first one. So you have a decrease in signal when flow velocities are very fast, when your TE is longer, and when your slice thickness is thinner. Get an increase in SNR, or what we call flow-related enhancement, when your flow velocity is slower, so think your venous blood flow versus arterial. When your TE is shorter, and when your slice thickness increases. So make sure you know these recaps really well. So here is a good image of our time of flight sequence where we are covered from basically the foramen magnum up to the corpus callosum. This is where the circle of Willis is. We are going to basically give our stationary tissues repeated RF pulses. So our white matter, our gray matter, our corpus callosum, optic nerve, the fat, retroorbital fat, all those things are going to receive multiple RF pulses. And then your flowing nuclei, which is coming up from your carotid arteries, are not going to receive any RF pulses until it enters the stack, or that slab. So they're not going to be saturated. All the stationary tissues, those vectors are going to be repeatedly beaten down so that they're fully saturated. And then your flowing nuclei will just get that first RF pulse. It'll go like either to 90 or whatever the flip angle is, and will appear bright because you'll have high signal from those fresh nuclei. So that's why on a time of flight, all you usually see, just like from that source image that I showed you earlier on, let's see where that source image is. here's a source image. Look at, these are all the stationary tissues around here. And look at how they're dark. And then your flowing nuclei that's coming up from your carotid arteries are going to be bright. And then it creates something like this. After your maximum intensity pixel, after you nip it. All right. Our next phenomena is called entry slice. So our first phenomena was time of flight. Our second phenomena is entry slice. This is sometimes referred to as the inflow effect. In this situation, the nuclei that flow into the stack are fresh. They have not been excited yet or beaten down. And then our saturated tissues are beaten down. You guys didn't think I would be talking about like domestic abuse of flowing nuclei today, did you? So, stationary tissue beaten down, meaning no signal, fresh meaning high signal, or brighter and darker. So there's so many different ways to describe it, right? And we also have hyper-intense, hypo-intense. So you guys are starting to get used to how the terminology in MRI. Like with your spine test, it's like your spinal cord is hyper intense to the CSF on a T1 weighted image. So you guys need to kind of have that mindset when you take the registry. So this is just showing fresh versus saturated. Fresh meaning you have a large component of that vector. So let's imagine it is a 90-degree flip angle. You flip that entire vector into the transverse plane, you have a large component of that vector. So that means more signal. Compared to our stationary tissues that have been repeatedly beaten down or fully saturated, and once they get 180, they have no transverse component, so they're going to have less signal. And that usually happens because we have really short TRs, so they're just going to receive multiple RF pulses, so it slowly reduces, because the tissues don't have enough time to recover. So they're going to be slowly saturated. So this diagram here, let's see if we can blow it up a little bit. So here, our stationary tissues, everything usually starts, once again, in the longitudinal axis that goes with V sub 0, our static magnetic field. Everything matches our vector, our net magnetic vector. So here we have arterial blood flow and venous blood flow. This is stationary tissue. If we have a short TR, here's our actual slice. This area right here has received multiple RF pulses already. So you can see here how that net magnetic vector has gone from pointing north to completely pointing south. So it's been fully saturated. But then your flowing nuclei haven't received those repeated RF pulses, so that it receives that first excitation pulse, so it goes 90. Remember, 90 is good. We want 90 because that's where our transverse plane is. And then it's going to create a high signal within that slice. Okay? And then sometimes you want to have a saturation band. You guys have had saturation bands, right? Where we put those below because we want to nullify our venous blood flow, because this is an MRA. So what the saturation band does is it applies an RF pulse before it even enters the stack. So that flowing nuclei, it has a good signal that matches up with our static magnetic field, but then it receives this saturation band, so it receives an RF pulse, it flips at 90, and then once it enters the stack, it gets another 90, and then it's fully saturated. So that's why we put a saturation band below on an abdomen scan to saturate venous blood flow that's coming up. Okay? So this is what we call a spatial saturation band, because we put it in a particular space. We put it maybe below the area that we're scanning, Or sometimes we put a spatial saturation band on a C-spine to nullify those carotid arteries, or, movement in the esophagus from the patient swallowing. So this type of saturation band is called a spatial saturation band. So these fresh flowing nuclei, it's great early on within the stack, but then as it goes deeper and deeper into that stack, unfortunately, it starts to receive more and more RF pulses. So you actually start to see a little bit of decrease in signal as that flowing nuclei goes deeper into the stack. So this is what this diagram is showing you. That first slice, when we got blood flow coming in, is going to be real pretty. Your vessels are going to be nice and bright, high signal, hyper intense. But then as it goes through the stack, depending on how thick that stack of area that we're scanning is, it starts to receive more and more RF pulses, just like our stationary tissue. So it starts to get darker and darker, and you get signal void. So our flowing nuclei, unfortunately, start to become partially saturated as it goes through that stack of slices. So here's a great example of that entry slice phenomenon. So this is, let's say, slice 1 up top. And we are going from the bottom of the patient, or basically our feet. And then this one over here will be slice 4, which is the top of the patient, closer to the head. And then this will be slice 2. And then obviously this will be slice 3. So in this situation, we want blood flow from the vein. And what's the major vein coming back up from the patient's lower half of the body?
IVC.
IVC, which stands for what?
Inferior vena cava.
Inferior vena cava. So let's find that. It's right here. Actually, let's use a different color. Okay. So our inferior vena cava, we want high signal from that. So we're doing an MRV of the abdomen. So where do we put our saturation band? Do we want it below or above our abdomen slices? What do you think? If we're trying to visualize the venous blood flow this time, where do we want that sat band? Above. Good. So we want the sat band above. So once again, right as you enter that first stack, first slice within that stack, we're going to have really bright signal from that flowing blood. But as you get deeper in the stack, look at what happens to the signal within the inferior vena cava. To the point where all the way at the top, the last slice, look at how we're starting to partially saturate or even completely saturate that flowing blood. So that's why sometimes you don't want to make those stacks too big, because they eventually will partially saturate. We want that to be bright and signal all the way up. And we'll talk about how we can do that. But look at our abdominal aorta. So remember, this was slice 4, but look at how bright that is now. So the blood flow from the opposite side is fresh compared to what it looks like as it gets deeper into the stack. So it's almost the reverse. So this is entry slice phenomena, meaning even flowing nuclei that's considered fresh will eventually become darker and darker as you go deeper into the stack. Okay, and we'll talk about ways to correct that so it doesn't happen. So here are factors that affect entry slice phenomena. Your TR, your flip angle, how thick your slice is, how fast the blood is moving, your flow velocity, and the direction of blood flow, meaning is it going head to foot or is it going foot to head? So we'll talk about TR first. I put the flip angle first, but TR. So if we have a short TR, this is going to leave less time between our excitation pulses, because remember, our TR is from 90 to 90. Our TE is from 90 to peak signal, but our TR is 90 to 90. So less time between excitation pulses means nuclei get saturated faster, because they're going to see that next excitation pulse a lot quicker. So those tissues are not going to be able to recover. So shorter TRs mean more saturation. We've seen this in gradient echo pulse sequences, and that's why we usually decrease our flip angle to compensate for that. So the nuclei are not as fresh, meaning less signal. So then our entry slice phenomena, which usually we want bright signal, decreases because they're not as fresh with shorter TR. Going back to our flip angle, once again, larger flip angles are going to create more saturation because the tissues are not able to recover. So higher flip angles or larger flip angles reduce entry slice phenomena. So once again, darker signal void. So signal void, short TR. Large flip angles, signal void. Slice thickness. Nuclei take longer to travel through a thicker slice than a thin. So that means the nuclei in a thick slice will more likely receive more excitation pulses than in a thin slice. So they'll become more beaten down and exhibit less entry slice phenomena. So to summarize, thick slices decrease entry slice phenomena. Flow velocity, so spins are flowing nuclei. Moving faster will receive less excitation pulses than slower moving blood. So faster blood flow will be fresher than slower moving blood flow. So this is almost the opposite effect. Entry slice phenomena will increase with faster blood flow. And the most important one is flow direction. So they asked on the registry which one is what factor is the most important in entry slice phenomena. It's direction, flow direction. And there's two different ways that you can orientate your slices. Co-current, meaning with blood flow. So imagine if you have arterial blood flow in the abdomen. Let's think about this for a second. If your co-current, is your first slice up top or is it down below? Up top. Because your abdominal aorta, your blood flow is going from head to foot, so we're going top to bottom. So you want, for co-current, you want the first slice to be at the top, then the second, then the third, then the fourth. But if it's countercurrent, for an abdominal aorta, you would put the first slice at the bottom. So you can see here how that will increase our entry slice phenomena. So our vessel is going to appear brighter for a lot longer if you're countercurrent. So this is a great way to maintain bright signal within that vessel. So going back to that image I showed you earlier that showed the vessel starting to get darker as you go deeper into the stack, a great way to compensate for that is to be countercurrent with your slices. So for an abdominal aorta, you want your first slice to be a lot lower.
So that will be the countercurrent, right?
Countercurrent is a great way to increase signal or increase our entry slice phenomena. So countercurrent is down here. That's countercurrent. So here's our blood flow, and then you're going to give it almost the last slice in the stack first, and then your first slice is going to be last.
You said the countercurrent increases flow?
Countercurrent increases your entry slice phenomena, and it increases signal within the vessel. So in co-current, the nuclei are flowing in the same direction as the slice orientation. These nuclei will receive more excitations and become more saturated, so entry slice phenomena will decrease. And then our countercurrent, nuclei will be in the opposite direction of our slice orientation. They'll receive less excitation pulses, remain fresh for longer, so it'll prevent that saturation deeper into the stack, so our entry slice phenomena increases. So here's a good summary slide, these next two, so really highlight these slides. Your entry slice phenomena, meaning you're going to have bright signal from flowing blood. Is most likely when in the first slice of the stack. That's just going to be apparent. Always that first slice is going to be the brightest. When using a long TR, when using a small flip angle, usually less than 90, in thin slices with fast blood flow, and when the slice orientation is countercurrent. Entry slice phenomena diminishes signal void. This means the spins have been beaten down. When we're using a short TR, a large flip angle, thick slices, slow moving blood, and we're setting up the slice orientation co-current. What's the most important parameter?
The co-current.
The direction. Direction. So this one is the most important. And then our third flow phenomena is what we call intravoxel dephasing. So we know that flowing nuclei will gain or lose phase position when rephasing with a gradient. So our gradients are along the entire core of the magnet, entire length of the scanner. And we know when we turn a gradient on, typically it creates a nice linear curve where we have a more positive end on one end and a more negative end on the other end. And that linear fashion makes it predictable. So that changes our precessional frequencies. Remember the Larmor equation? As our precessional frequencies change, so does our Larmor equation, just a little bit. The only thing that stays constant is our gyromagnetic ratio and our field strength. The field strength, I'm sorry, that changes just ever so slightly. So our only thing that stays constant is our gyromagnetic ratio. So then our precessional frequencies are going to change ever so slightly along the length for the magnet. So if we compare a flowing nuclei next to a stationary nuclei, that phase change is going to be a lot greater with that flowing nuclei. So imagine and when we talk about different phase positions, they always refer to like the clock. So imagine a stationary tissue that was at 12 o'clock. Maybe it's only moved to about 2 o'clock. That's stationary. But moving nuclei, if you talk about the clock, it started at 12 position, but then due to the gradients causing them to speed up or slow down rapidly, it's now moved to 6 o'clock. So when these vectors are not matching up, this equals a greater decrease in our SNR. So that's why we call it intravoxel dephasing, because sometimes within a voxel here, we have spins that are at 2 o'clock and we have some spins that are at 6 o'clock. So anytime the spins are not matching up in where they are in position of the clock, it's going to decrease our overall signal within that voxel. So that's what intravoxel dephasing means. So you can see here, as you have a larger voxel, you have a greater variation in where those spins are on that clock. So this larger voxel will have a lot lower signal than this smaller voxel over here, because you have just a little bit of variation in where the spins are in terms of their phase. So to decrease intravoxel dephasing, use a smaller voxel. Increases our spatial resolution too, so a couple of good things. So the degree of intravoxel dephasing is dependent on the turbulence of the blood flow. And remember, we can only compensate for what? First order, second order, third order? First order, which equals what? Time of flight, our laminar blood flow. First order equals laminar. Constant, something we can predict. In MRI, if it's not constant, usually we're not going to get signal from it. So with intravoxel dephasing, even if we use what we call gradient magnetic nulling, which corrects for those phase shifts, if it's not laminar blood flow, we're still not going to get signal from that vessel. So other types of blood flow that is not laminar cannot be compensated for. So only first order motion can appear bright on our MR images. So just kind of a recap for today. Let's see how much more we have here. We'll take a little bit of a break. We'll recap. We talked about flow mechanics. So we talked about our laminar, vortex, turbulent, stagnant flow. Spiral was also one of them we talked about. But remember, laminar is first order, vortex second order, turbulent third order. We can actually get signal from stagnant flow, but remember, it's just like urine within the bladder. It's just sitting there, so it's going to appear bright in our T2 image. We talked about the three types of flow phenomena: time of flight, entry slice phenomena, and intravoxel dephasing. And then tomorrow, or next week, we'll talk about how we can compensate for those flow artifacts. We'll talk about gradient moment nulling, pre-saturation bands, and even echo rephasing. So let's stop there, because I feel like that's enough for today. And then we'll go over that next week. We are going to have a quiz at the end of class next week, okay? So be prepared. We're going to be talking about the rest of this PowerPoint, then we're going to take an in-class quiz. So if you're a little rusty on what we talked about today, watch this echo lecture or YouTube lecture again, before you come to class next Wednesday. We're gonna have an in-class quiz, 20 questions, no notes. So, just a prep for that.
Is it on paper or
It's on paper, yeah. You guys are gonna do it on paper, the R2 BMS are gonna do it online.
So Mr.
Also this weekend? You guys have it?
If it's in the system, don't worry about it, that's just for the R2 BMS students. I'll change the date for that. So, that date we're just putting in there.